So, hello, good afternoon, everyone. Here we are to our fourth research group seminar from our first international meeting on dental research, promoted by the Federal University of Goiás. Thank you very much for joining us. I have the honor to host this seminar focused on oral health of elderly patients. And we're gonna address two specific topics. The first one is implant for geriatric patients, and the second one, caries management for older adults. And I have the great pleasure to have here with us dear colleagues and friends, Professor McKenna, who we call Gerry, a good friend from the Queen's University of Belfast in Northern Ireland, United Kingdom, and also Professor Murali Srinivasan from the University of Zurich. Thank you very much for accepting our invitation to be here to contribute to our seminar and our meeting, our first meeting on dental research. Thank you very much. We are going to have the two lectures from our invited guests. And the first one will be Murali. And please, Gerry and Murali, say hello for our audience.
Hello, everyone. And, thank you very much for the invitation to come and speak to you today. Very nice to see you, Cláudio.
Okay, thank you.
Hello, everybody. It's a pleasure to be here. Thank you for the invitation, Cláudio, and your team. It's quite exciting, and I look forward to this session at your first conference. I hope it's an interesting one, my lecture.
Okay, thank you very much. I will give now a brief introduction for Murali here. Murali is our first speaker, and he is the professor and clinical director of the Clinic of General Special Care and Geriatric Dentistry of the Center of Dental Medicine at the University of Zurich in Switzerland. And Gerry is the professor researcher at the Center of Public Health at the Queen's University Belfast. Okay, both of them were former presidents of the European College of Gerodontology, and they are very well-known researchers, and they are referenced in the field of oral rehabilitation and gerodontology, and it's a great pleasure to have you, both of you, with us here. Okay, Gerry? We will see Gerry in a few minutes, and now we're going to start with Murali. Okay? Murali is a specialist in prosthodontic and implantology. He received a specialized training in Sweden, Switzerland, Netherlands, and Germany. He has also had previous practice in India, Dubai, received an ITI scholarship in Basel, Switzerland, and then completed his ITI scholarship program in Geneva in 2011 with the team of Professor Frank Miller. And then he completed his education in the University of Geneva, 2015, as a master's degree in advanced dentistry and reconstructive dentistry, and had his Swiss board certification in 2016. Now he's private docent in the University of Geneva and is based in the University of Zurich. He is, as I said before, he's currently the clinical director is working on prosthodontics and implantology, dental care for the elderly and disabled people, with CAD/CAM technology in removable prosthodontics, hospital administration, marketing, business development, and many things that he does in Zurich. Professor Srinivasan has received many awards in the fields of geriatric research. We first met in the IDR meeting in London, then in Vancouver. It was a great pleasure to meet you there. And since then, we have been working together. We have a few publications in collaboration with Murali in our group here. And I think we have a very, very nice partnership in this last 2 years. And I hope we can continue to work together. And it's a great moment here to strengthen our partnership and our friendship here in this meeting. Thank you very much for being here, Murali, and the screen is yours.
Thank you, Claudio, for this really elaborate introduction. And I'm very happy to be here for this presentation. And also, I wish you great luck for your first meeting, and I hope that I'm able to contribute to a very good extent for this meeting. Right. So, as Claudio has just introduced me and told you that I'm from the University of Zurich. Yes, I was in Geneva before. Since the last 2.5 years, I've been the clinic director and professor of geriatric dentistry in Zurich. As you can see on the background, that's our building, and on the ground floor is our entire clinic. We have a clinic of about 60 people, about dentists, dental technicians, dental assistants. So we mainly cater to patients who are elders and with complicated health conditions, as well as children and adults, not children, but adults with special needs. So today my topic will be dental implants for the older adults. I'm going to talk about the geriatric treatment concepts for implant-supported removable reconstructions. So the scope of my lecture would involve a little bit on the background and introduction. I would talk to you about the indications and goals of implant therapy in elders, then would tell you the implant configuration and the choice of attachments, which are usually quite successful in removable overdentures in adults, and then finally finish off with some conclusions and future perspectives. Now, we know that the world population is aging, and the number of aged adults are increasing all over the world. Before, it was just in the Western, in the developed countries, but now we are also noticing a trend where the number of older adults are increasing even in non-industrialized nations. Now, although we would like to feel good about the added age, or let's say humans living up to an advanced age, it does have an impact on aging. Elders are usually come with compromised health. If they have more than 2 or 3 chronic conditions which require medication, then they are termed as multimorbid. And multimorbidity is a very common condition in age-advanced elders. Of course, along with this, there's also a huge incidence and prevalence of cognitive decline, which can be mild or severe in such older adults. Along with these, there's also the occasional frailty, which is very common in elders, and also if they do encounter strokes or other events, they might have some physical handicaps. Now, what is important is, if you look at it, most of the time, polypharmacy and this loss of autonomy increases in these elders. And then there is, because of polypharmacy, drug-induced hyposalivation. And then because of the loss of autonomy, there's dependency for oral care. And as a result of this, what happens is the consequence is poor oral health. And when we talk about poor oral health, this would invariably be in low plaque control because they're not able to clean, might lead to increase in the number of coronal caries and root caries, which happens. If these are not treated, then there is there is a deterioration of the situation, and there is untreated oral infections, which can lead to tooth loss. And tooth loss in elders will invariably reduce the oral health related quality of life. Now, of course, tooth loss does exist in the age advanced elders because of the reasons I've just stated. And we must ensure that the best possible treatment is afforded to the elders. And the main question which usually arises is, are elders too old for an implant? Of course, when you see this study from Professor Schimmel from Bern, he had published this paper a few years ago where they did some demographics on their patient pool who come in for dental implants. And they have noticed in the last few years that the number of patients who come in asking for implants or are indicated for implant therapy are primarily in the older age group. Of course, they do have younger patients who need implants as well, but the number of elderly adults who come in for dental implant treatment has considerably increased in the last few years. Now, the next question is, do implants survive quite well in the elderly? The first systematic review, which I did a few years ago, we checked on the 10-year implant survival for adults over 65 years old. And we found that the 5-year implant rate was about 96.2%, and a 10-year implant rate was around 91%, which is quite good for adults who are old. And when we redid this systematic review, I had the pleasure of working with Professor McKenna, Professor Müller, and Professor Schimmel as a part of the ITI consensus, and we increased the age inclusion for 75 years and over, and checked if the implant survival is quite acceptable. And we discovered in the systematic review that the 5-year implant survival rate for adults over 75 years old was around 96.1%, which is comparable even to younger adults. Now, our conclusion was quite simple, and we stated that implant prosthesis in geriatric subjects are a predictable treatment option. So there is no reason why age should be a contraindication. Now, the real question comes, are the older adults too sick for an implant? Now, this is a quite pertinent question because we do not have, first of all, they come with a lot of chronic diseases. And because of this, we would like to know whether some of these diseases affect implant survival. And when we investigated in the same systematic review, we found we took the most common chronic diseases which affect the elderly adults according to the WHO, this list, and a few other conditions like hyposalivation and the use of anti-resorptive therapy and other situations like neurocognitive disorders. And we noticed that there is not exactly too much data available because, and the evidence what we have is mixed. Some say that it is absolutely contraindicated in certain conditions, but others also show about 100% implant survival rate. So what we have to do is, it's quite clear that certain chronic diseases are certainly contraindicated, but others not. So I think it is quite important that a proper case planning is done and the medical history is properly assessed before doing an implant therapy. But what we do know is we must stand clear of IV anti-resorptive drugs. And this is quite important because medication-related osteonecrosis of the jaw is usually a complication if it's not checked. What is the most practical problem we will face in elders is that the risk of gingivitis and peri-implant mucositis. This was a study conducted in Geneva by one of my colleagues, Simon Meyer, for his specialization in perio. And what they did was they included all adults with implants, elderly adults over 70 years of age with at least one implant in the mouth. And what they did was they did 3 weeks of no oral hygiene, and then they checked the plaque levels and other oral inflammatory conditions, and then they redid the hygiene and then checked again. And what they found out was, although there was less plaque accumulation on the implants, the peri-implant mucosa showed a stronger clinical response than the gingiva. And what's another important aspect is, after the plaque control was reestablished, the inflammatory responses, although it reduced, it did not go back to the original levels, and it took a considerably longer time for the inflammation to actually go down. So what is absolutely important, and what we can understand from the study, is that we must make sure that oral hygiene is absolutely cardinal in elders, because once the inflammation sets in, it takes a long time to go back to normal, and it does not go back to its original levels before the inflammation set in. So this is important for us to make a note. Now, another aspect which is quite interesting is that even if you give free implants, there is a possibility that elders might refuse to have implants. And this was a very classic old study which was published almost 15 years ago by the Canadian researchers Walton and McKenna. And they proved that even if you give away implants for free, the whole treatment for free for certain elders, they might actually refuse it. And the most common reason for refusing the implants was because of the fear of surgery or the risks involved in surgery. So what we need to understand is it's important that we also educate the elders, and we don't have to necessarily always convince them, but we have to try and outline the importance and the benefits. So a well-educated elder has a better chance of accepting this implant. And a similar study was conducted by Professor Müller in Geneva a few years later. And what they found was, she wanted to see what was the attitude of the elders towards implant treatment. And funnily enough, even in an industrialized nation like Switzerland, most, as you can see from these results, there was about 27% of the people who actually did not even know what an implant was. And what she also published was the risk factors for declining implants. Usually women decline. It's important also the type and quality of denture. This is also a risk factor. If they already have a good set of dentures, they don't necessarily go in for an upgrade with an implant. And also the main aspect was little knowledge on the dental implant therapy. And finally, the fear of being hospitalized. But none of them ever said age was a reason for refusing implants, or age was a contraindication. So, having talked a little bit on the attitude and what the implant therapy is in elders, I would now like to go into the main indications and goals of implant therapy in elders. Now, as we all know, the first and the most important indication for implant therapy would be, not only for elders, for everybody, is to avoid the possibility of a removable dental prosthesis. I mean, if you can give a fixed implant therapy, especially in the mandible, if it's possible and the clinical situation permits it, I think that would be a great reason to do this. A second reason is, if the patient is already, or the elder has or is using a good removable partial dental prosthesis, and for some reason the abutment tooth which supports the prosthesis or retains the prosthesis is lost, this could be a reason for implant therapy, where you add on a strategic abutment in the form of an implant, and then this can help maintain the existing prosthesis. And this is quite useful in elderly adults because they have limited finances and also time, and their health conditions might not permit them to go through the entire treatment, a new treatment all over again. So it would be useful in preserving the existing partial dentures, and the retention is maintained. And the most important thing is the elder or the older adults would very easily adapt to the same prosthesis, because a new prosthesis takes some time for adaptation and comfortable, and for it to be comfortable. Now, another aspect is this is a concept which they do in Bern. Professor Schimmel, this is one of the cases of Professor Schimmel where you can also add a short or a smaller implant in the distal aspect of your distal end saddles, where you can stabilize the distal extension removable dental prosthesis so that it is more comfortable. And it does not always have to have an attachment at the distal aspect. It can just be an implant with a healing abutment or a cover screw, just so that the prosthesis doesn't sink and it stabilizes it. It would be good for many aspects, including function and comfort of the patient. Most importantly, preservation of the distal bone, which is usually lost because of distal end saddles, which cause resorption in that area. And finally, in my opinion, the biggest and the greatest success story of implant therapy is the stabilization of the mandibular complete dentures with 2 interforaminal implants. I think if there is a huge success for implant therapy in the world, considering all aspects of indications in fixed and removable prosthesis, this by far is the most and is the biggest success story, because this has really been documented, high level of evidence, and it has changed lives and the oral health related quality of life for millions who have been suffering with poor fitting mandibular dentures. Now, as we all know, the main goals of implant therapy in elders is to restore chewing function, maintain and restore it. So if you see these videos, what you see are 2 elders chewing very comfortably. Would anybody be able to guess what kind of prosthesis they have in their mouth? Is it fixed, removable, natural teeth, or complete dentures? Well, you would be interesting to know, firstly, they're chewing gum. Chewing gum is not so easy for a person who is edentulous, completely edentulous. So the patient on the top has a conventional upper denture and a lower mandibular overdenture supported by 2 ball attachments, and the patient at the bottom again has a conventional upper denture and a lower implant supported overdenture on CAD/CAM milled bars with long distal extensions. Now, it's interesting to see that even though the upper denture is not implant supported, it is able to perform the function. And this must be a point which I would like to make, because everybody assumes that upper dentures also might need implants to perform difficult functions. So I think a good prosthodontist would argue and say he would not have any problems in getting a very good function with just a conventional upper denture, which is absolutely the case. Now, the next question comes to the mind is a removable partial denture or an implant supported overdenture as good as, does it restore the chewing efficiency in a very acceptable and satisfactory manner? And this study very clearly shows that the chewing efficiency is definitely quite good with implant supported overdentures when compared to conventional complete dentures. And as you can see in the graphs, different attachments have different levels of chewing efficiency. The magnet fairly does poorly comparing to the bar clip or the ball attachments. Now, we talked about restoring function and nutrition, but the question is, does nutrition actually improve with implant-supported overdentures? And the answer, unfortunately, is that implant overdentures alone cannot improve the nutritional intake of the edentulous persons. And this is quite natural, because unless the patients are educated, trained, and counseled about diets and taught that with the existing overdentures, their diet can improve and they can actually chew and eat better foods than before. And unless they're trained, motivated, and counseled, their nutrition will not improve because they will still function and eat the same kind of soft foods which they were using or they were eating before they had the implants to support their overdentures. Now let's come to the goals of implant therapy. When we, in elders especially, for these would be considerations when you think about elders. And the main aspect would be to minimize the treatment burden. When I talk about treatment burden, I'm not just talking about the invasivity of the surgery or the healing time or just the costs. All put together would be the treatment burden, and we must try and reduce the treatment burden for elders for obvious reasons. And when we talk about reducing the treatment burden, what we can do in a first step would be to reduce the surgical morbidity and try and adapt surgical procedures or other clinical protocols which reduce healing time. Try and avoid all heroic augmentation procedures because it is absolutely not required. And if you have to do sinus lifts, then try and do the osteotome, Summers osteotome procedure for sinus floor elevation. And of course, when it is possible and indicated, do a flapless implant treatment because this really, really is very good and it can reduce the surgical morbidity and healing time greatly. But a proper case selection is required. And when possible, use shorter implants or reduced diameter implants. And of course, all this must be performed with affordable costs. Now, having said all this, you have to take into factor certain predictors which are very specific to elders. For example, the first point would be cognitive impairment. Now, you would be amazed how this plays a role. For example, in this video, you see this lady. She's has very severe cognitive decline. We've just handed her a set of upper dentures, and she is hesitating to put it in her mouth because she thinks it's a wedding ring. These are the kind of patients we see. Next aspect is manual dexterity. You must make sure that the treatment and therapy, what you do, or the design of your prosthesis permits the patient, if not at the moment you're doing the treatment, at least allows or takes into consideration a possible future problem with the manual dexterity where they are not able to insert or remove or clean the prosthesis. And then another aspect is involvement of caregiver and family involvement. Whatever treatment you do, whatever prosthesis you design, it's important that you must have the caregivers present there who regularly take care of the patients, because they must understand how to insert or remove the prosthesis, clean the prosthesis, or clean the implants. If they don't know how to do it, a dependent elder cannot do it on his own. And it's important that the family is also involved, because then the family is responsible, or the primary caregivers or the family members can educate the tertiary or the secondary caregivers. And like I mentioned before, an effective diet plan has to be structured, otherwise the nutrition will not improve. And most importantly, motivation. The elder has enough problems, health-wise and otherwise, and motivation is important to make the elder feel or perceive that oral care is important for his or her general health. Because most of the time they neglect oral care because they think it's a very small aspect when it compared to the numerous other health problems they have. And this can only be done by proper education and motivating the elders. Now let's come to the prosthesis design consideration. Firstly, you must make sure it's easy handling. In this video, you can see that this edentulous patient with a implant supported lower mandibular, lower overdenture She's not even able to remove it. Of course, I would like to pride myself and say, wow, this is a fantastic prosthesis. The retention is excellent. Okay, she's a young, old person who is edentulous, and she's able to manage. But this amount of powerful retention is not indicated in an elder. So although we'd like to say that this is a very successful treatment with excellent retention, problem is that this is not indicated for all kinds of edentulous patients. Age and other factors must be taken into consideration, and we must make it that it is easy to handle by the elder who's using it. Now, another aspect is the retentive element should be, you should be able to reactivate it or reduce the retention, or it must have options where you can increase or decrease it, and it must be easy to repair. And there are many products in the market or many attachments which give these options, and these must be your first choice of options, because at some point the elder might want a very retentive prosthesis, but after a while it becomes difficult for the elder himself to remove the prosthesis. And this is an important aspect because it should be, as I explained, it should be reversible. And this is the back-off strategy, which is usually explained a lot by Professor Müller in most of her lectures, and this is quite important. As you can see, the lower set of slides, starting from the left, this patient started with locators, didn't like the retention in the conventional locator. We switched over to another system called the CM Lock Flex because the inter-implant angulation was more than 60 degrees, and at that point, and because there was a problem keeping it clean, we moved it to, the SFI anchor from Straumann, and then we moved it to CM Lock Flex, and then the patient was still not happy with the retention, so we moved it again to the bar, and the patient was very happy. But this can be very well moved backwards in time in case we need to change it. And whatever type of prosthesis you give, it's most important that you give the appropriate tools to the elders or the caregivers to clean it. And as you can see, these are different cleaning tools for different kinds of attachments. The first one is a ball attachment, and that brush is shaped with a slightly convex, and where the ball attachment can be brushed very nicely and the area under the ball attachment can be cleaned. And this special brush is to clean what do you call it? The space on the conventional locator, which is used to tighten the locator. This brush is very optimal to clean that area. And of course, for bar attachments, make sure that your bar design is such that it not only permits the use of a dental floss or a super floss to clean, you can also insert a brush when the time needs, because not all elders will be able to insert a floss and clean the bar. And at some point, if they're more comfortable in using the brush, they should be able to use. So your design of the bar or the superstructure must already take into consideration with the different aspects. You cannot just give one option and say this is the only way to go, because it's not always possible by everybody. Now, the million-dollar question, removable versus fixed. Do removable prostheses or removable overdentures actually quite work as well as the fixed? And this is a classic study, a very gold standard study made by the famous researcher Jocelyn Fine in the 90s, and they assessed within subject comparisons of implant-supported mandibular prosthesis. They had 15 edentulous patients. The study was a crossover design for 2 months, and it had implant-supported prosthesis in the mandible and implant-supported fixed versus removal. So they did a psychometric evaluation, choice of prosthesis, and a masticatory function. And what they found was it was not very significant. There were equal distribution of the number of patients who chose fixed and who chose removable. And some of them chose fixed because of the stability and the chewing comfort, and it was easy to clean, while the ones who chose removable prosthesis also chose it because it was easy to clean. Aesthetics were sometimes better, and again, stability. But what is important from the study is patient perspective is very important. Even as dentists, we think that a fix would be better than a removable for this particular patient. It's actually the patient whom we should allow to decide what they want. And what was most important they did was the long bar overdenture appears to be no less efficient than the fixed prosthesis. So if you actually do a bar design, it actually functions quite good and as good as a fixed prosthesis in the mandible. Now let's have a look at the implant configuration and choice of attachments. Now, today in the market, you have so many implant systems and so many implant types. Now, I'm just showing you one particular brand which has so many options. And to me, it's much better to stick to one brand which gives you all these options rather than look for these different options in different brands. And of course, Switzerland is the land of Straumann. So we do prefer Straumann because of all the guarantees they give us, even if it is a bit expensive. Now, when it comes to implant overdenture therapy, I always prefer the standard implants, the tissue level regular neck from Straumann, or you could have a tissue level implant from any other brand. Why? Because I think the the collar, the polished collar gives excellent soft tissue compatibility, and it always keeps the attachment working interface is above the micro gap. And this, for me, there are no studies which show whether this has a positive benefit or not. But as a prosthodontist and as a clinician, I would really not like to keep working in the implant bone interface area, and I would like this to be a little bit above so that area remains pristine, the osseointegrated part, and whatever prosthetic work you want to do, impressions or otherwise, it all stays above the tissue surface, and basically the osseointegration is not moved. Many might argue and say there is no effect, maybe, but for me, it's just a comfort factor. For a removable overdenture, I think a tissue level implant is always a very good choice because aesthetics is not a concern. Now, when it comes to if you can't do a standard implant or a tissue level 4.1, you can always go for the other configuration, which is the narrow neck crossfit, which also has a nice polished collar, and it has the same amount of soft tissue compatibility. And of course, you can also see that while you work on this, the working interface stays above the micro gap. But you must take into account in this particular design, as you can see in that picture, there is still a little bit of soft tissue which sort of grows over. And I don't know if it has to do with the parallel shape of the implants, because in the regular neck, because of the tulip collar, I think it sort of spreads and keeps the mucosa at base. But in this, it sort of grows over it. Well, anyway, this would be an option if you can't use the tissue level. Now, when it comes to reducing the invasivity, if you really can't manage with regular length implants, short implants seem to be a good option. Of course, this is a case which I'm showing you with fixed reconstructions, but this is a case where it shows you about 8 years in situ. It was treated by one of my friends in Geneva, and it's a very, very nice case, and I don't know whether this patient still comes back for follow-up. But when I did do a systematic review many years ago on the Straumann 6mm short implants, what I did notice was that the failures of these 6mm implants seem to be slightly higher in the maxilla than the mandible. And the majority of the failures which did take place were all early, before loading. So it would be interesting to know that if these short implants do fail, they fail before loading. And in the mandible, the success rate is almost about 98.6%, which is quite good. Now, when it comes to ultra short implants, the Straumann has now a 4mm implants, which seems to be a good option, but we don't have much evidence. except this study, which was published in 2011, which is a very experimental study where they used multiple 4 millimeter short implants, and they had a 1 year or a 2 year survival rate for fixed reconstructions, and they were all splinted, about 92% success rate at 2 years. Now, what about the same study, which was published, same study, same authors, they published a 5-year report, which is about, again, 92.2%, which is not too bad. And they did notice that the peri-implant marginal bone loss was acceptable according to them. But 0.53 millimeters of bone loss on a 4 millimeter implant is quite a lot, because that's almost to 1/4 the osseointegrated space. So I think 4 millimeters is too short, but the evidence shows that it can be used for fixed reconstructions. Now, what we do need to know is, can we use these short implants for removable prosthesis? And this was a study which was published in 2016, and where they had 10 patients, atrophic mandible. Well, they say it's atrophic mandible, but unfortunately, when you look at the x-rays, there seems to be enough bone in the mandible for longer implants. Anyway, it was published in Clinical Oral Implants Research, so I'm not going to argue with the credibility. So atrophic mandible implants, about 60 implants, 6 implants each in each patient. And what they did was they placed 2 regular length implants in the interforaminal regions and 4 posterior ultra short implants of 4 millimeters. And they gave a screw retained fixed overdenture on this. It's not a removal overdenture, but a fixed overdenture. And after 1 year, what they did was they checked that there was only 1 short implant that failed, and there was a 4 millimeter survival rate for the 4 millimeter implants at around 97.5. And when they did check the peri-implant marginal bone loss, they declared it was similar. So, but we must consider this, we must take these results with a little bit of caution, because it's only 1 year follow-up. I haven't checked if there is a follow-up for this particular study, but anyway, it just shows this. But these are another option, which if there is bone volume missing, you could use mini dental implants, which are really doing very well in the market these days. I'm not a big fan, but it seems to work quite well, because most of these studies show that there's 100% implant success. The chewing performances are quite nice, and it's really becomes better as the follow-up years increase. And of course, if the cost is a factor, it would be very, very good option. But the only negative aspect about mini implants is they don't come short. So if you have to really place a mini implants, you need at least minimum 10 millimeters of bone height. That is quite important. Now, when it comes to implant configuration, let's talk about the implant number. And I would like to talk about the implant number based on the jaw. So the maxilla. Now the question is, do we really need implants in the maxilla? A good prosthodontist would say no. But if the patient insists, I want a palate-free prosthesis, then you don't have a choice but to place implants. Now, what would be the right number? For me, a minimum of 4 implants, and is what the ITI actually recommends, 4 implants. And it's important because the benefits are, it increases chewing efficiency, or that's what we perceive, patient perception and satisfaction, and alveolar bone preservation. Now, here's what I will argue to and pro and con. Well, we think that chewing efficiency and patient-related outcome measures increase. But as the study has shown us, they checked in 2 groups, 25 patients, one with freestanding attachments and the other one with bars. And they checked their outcome measures was mixing ability index and also the patient satisfaction questionnaires. Conclusions: they checked that there was a strong correlation between the mixing ability and general satisfaction questionnaire against the CCDs. And there was no difference between the groups in the mixing ability index, which means the chewing efficiency was pretty much the same. But for some reason, the patient satisfaction was higher in the group with bars. Now, the effect of palatal coverage. We make such a big deal out of this palatal coverage for patients, and we think that this is one of the prime indications to give implants in the maxilla for overdentures. This study concluded that the attachment type made no difference in the oral perceptual ability and the patient satisfaction. And what was very important was palatal coverage did not influence either one of these two outcome measures. So for me, the main reason to place implants in the maxilla would be to avoid the palate. But studies show it doesn't make any difference. But if there are patients who request it, I think we should take it into factor. What is very important is this is something, it's not been proven, not many studies exist, but it would be interesting to see that if you had a lower implant overdenture and in the upper jaw conventional complete denture, there is a possibility that perhaps a combination syndrome related effects can occur, and this could increase or quicken the anterior alveolar bone loss. And this study checked this in 9 patients with maxillary complete dentures and mandibular implant overdentures. And they had a control group with only 4 patients, and they had conventional complete dentures. What they measured was blood flow in the maxilla anterior region. They checked the residual ridge resorption measured at 1 year post-intervention. And what they concluded was blood flow was significantly lower in the maxillary anterior region in the implant overdenture group. And this may contribute to greater residual ridge resorption in the anterior maxilla. So if perhaps to preserve the anterior maxilla, placing implants might be a good idea. Now, the million-dollar question comes usually, which is better for the maxilla, splinted or freestanding attachments? Should we go in for bars or should we go in for unsplinted attachments like locators or ball? Now, this was a study which was published in 2019, and what they said was implant and prosthetic survival rates, patient satisfaction with maxillary implant overdentures on 4 implants were not influenced by the overdenture design, and no statistical difference was detected between the groups. Now, that's interesting because normally one would think that for the maxilla, it's always better to have a bar. But then there are also other complications associated with bars. So it really doesn't matter. But what has been published is when it comes to peri-implant health, although there was no differences according to this study between the outcome measures for peri-implant health, the bar, and it was not statistically significant. However, they did conclude that the bar group was more vulnerable to have more peri-implant health problems than the freestanding or ball attachments. Now, that's something which is quite interesting and which I have also seen in my personal experience, that bar patients do have a problem maintaining, although it is quite reversible most of the time. Now, when it comes to implant number and positions, for the maxilla, for the mandible, it should be a minimum of 2. I know I'm going to cause some waves in Brazil at the moment, because I know Cláudio has published a lot of papers with a single mandibular midline implant, and it's highly successful and it's recommended for developing countries because of the cost issues. But I would like to always play safe and place 2 implants in the implant in the mandibular interforaminal region to have a better success. And for the moment in Switzerland, we don't have the cost as a factor, but I think as the ITI also recommends, 2 implants in the interforaminal region is the tried and tested method, and can be the minimum and is usually declared as the minimum standard of care for completely edentulous patients. Now, the positions of these implants in the maxilla and mandible are as shown. Ideally would be in the canine and the first molar regions for the maxilla. If that's not possible, the second option would be to place it in the lateral incisor regions and the first premolar area, or the canine and the second premolar area. For the mandible, 2 canines on the 2 canine region, or if you want to go for 4 implants, which is, I think, is not necessary for the mandibular overdenture, you could place it in the lateral and the first premolar area. But stick to 2 implants in the mandible, in the canine area, gives great success. So coming back to the point, a minimum number would be 4 for the maxilla. And like I mentioned before, why not a single midline implant? Well, for me, personal reasons, and also because of this systematic review I conducted a few years ago. There's not many studies, but of course I haven't rerun this systematic review now because there's a lot more evidence which is now available, and perhaps it might change my opinion in the future. But like I mentioned, the minimum standard of care is 2 implants in the mandible, and these are the positions. Sorry, but these slides are repeating for some reason. I don't know why. So now, when it comes to choice of attachment, splinted versus unsplinted. If you have limited inter-arch space, hygiene is a problem in maintaining in these patients. And if you want easier manipulation of the prosthesis and you want lower initial costs, I mentioned low initial costs because these attachments are not as expensive as bar attachments or custom-made bar attachments. So the choice would be for you to go for not splinted attachments, such as ball attachments, which is considered the gold standard, or the different stud attachments which are available in the market. Depends on the region you come from and what's available. Now, as far as the spherical ball anchors are concerned, for me, it is the gold standard. I would like to nickname this attachment as a Casanova because, as you can see at the bottom, it can accept a lot of different female attachment matrices. It's compatible with a lot of different kinds of female matrices which are available, and these can pretty much be used in different situations clinically where the height restrictions in the prosthesis exist. And as you can see, this is one of the really gold standard attachment, the ball attachments. Unfortunately, when it comes to inter-implant axial discrepancies, if they're not perfectly parallel and they exceed about 12 or 13 degrees, then these ball attachments do not function very well. At least that's what we have found in our lab studies. Now, to compensate for this limitations with the interaxial alignments for ball attachments, locators were brought in because they allowed a discrepancy of up to 40 degrees. And they also had different strengths. And locator is considered one of the most popular attachment system for overdentures. Unfortunately, the locator has what is known as a nuisance factor, where there is always plaque and calculus or other aspects which get stuck in that central hole on top of the attachment head. And this might not seem a big problem, but when it comes to elders who are dependent for care, it's a huge problem because they're not able to place the prosthesis back into the place, or it's not clicked in properly, and then there are huge other problems. Now in Geneva, Martin showed me this trick a long time ago, and I do this all the time. So if I have conventional locators, I close the central hole on the top with a temporary photopolymerizable resin material like Telio, and then keep it closed. And every time the patient comes in for a checkup, I remove it and clean it up, and then put in another coat of cement so that it does not have any food impaction or other impaction. So, and of course, depending on the angulation and what kind of retention you want, you have many different options. But of course, the first 3 are out if you use this if you use the Geneva solution to close the holes, but you can do pretty much well with the remaining 4 inserts because they have pretty much the same strengths. Now, the new system of locator which has come has, as they claim, has an improved surface because the old locator had a lot of problems with wear. So this one comes with an improved surface. They say there's less wear, but it's been on the market only for the last few years. So we don't know exactly whether this problem has been taken care of. And of course, there is no more nuisance factor, as they say. And what's most important is this allows an inter-implant angular discrepancy of up to 60 degrees. So if you had someone really, if an implant surgeon had a really bad day and he placed these 2 implants totally looking the other direction, and it's about 60 degrees with discrepancy, you can use this attachment. And of course, there are other Swiss attachment forms which come with different kinds of inserts. This is a CM lock, which I personally like a lot, and it has the pectin inserts. It's not the nylon inserts of the locator. The CM lock allows, just like the conventional locator, 40 degrees, and the CM lock flex, as you can see, can be used to correct 60 degrees. You correct it and you can make it parallel, and then you can use this also with pectin inserts. Now, the most recent of all these attachments was the Novalock from Straumann, and this one also allows a correction of up to 60 degrees. But they don't, they come in 2 forms. One is the angulated, one is the parallel. So the parallel allows to about 40 degrees in between the implants. And if you want to use the angulated ones, you can use up to 60 degrees. Now, when it comes to the choice of attachments for bars, all the contraindications for the unsplinted attachments are the benefits and the reasons why you should use bar attachments. For example, where the implants have been really placed in a very, very non-ideal angulation, exceeds 60 degrees, or multiple implants in the same jaw where you try and get the angulation correct, this would be a situation. What's important is these bar attachments, to fabricate them, it takes a lot of money. But studies have shown that in the long term, the maintenance costs for these bars are a lot less than the stud attachments, because the stud attachments need regular recalls, change of inserts, sometimes wear the attachment head. So in the long run, the bar might be a more cost-effective solution, but the bar may not be a proper solution if the elders do not have manual dexterity to take care of their prosthesis. And of course, the disadvantage is the bars need ideal space requirements within the prosthesis, otherwise it can hamper with the teeth settings and also with the aesthetics. And you might have repeated repairs where the pontic teeth fall off from the dentures. And they're not easy to fabricate, but of course, with the advent of CAD/CAM technologies now, you can mill these bars. And I have mentioned high initial costs, but right now with the CAD/CAM technology, these initial costs have been reduced to a very great extent. Now, if you ask me which attachment is the best, what is better than the rest? Or does one specific attachment stand better or perform better than something else? What would be the choice? Well, this was a systematic review, a Cochrane systematic review published in 2018, and it was very interesting for me to read because their aim was to assess different attachments used for upper and lower jaw implant dentures. And they checked the success, the wear, patient satisfaction, and costs. Now, they included 6 trials on adults with complete tooth loss, 294 mandibular dentures with 1 or more implants were included. And however, they did not find any eligible trials for the upper jaw denture. So if you researchers are listening, I think it's good to do studies with the maxilla with different attachments with the same implant systems. It would be a good way to go. Now, the key results was they found that insufficient evidence for any significant differences for lower jaw attachment system. So they say almost all of them are similar or dissimilar in function. They say absence of evidence for the upper jaw implant denture attachment system, so they can't conclude. And they point towards the researchers to say attention to trial design, same implant system, same number of implants, different attachment system, longevity, and patient preferences. When I read this, I was so happy because from 2013, I was doing a randomized control trial in Geneva with Professor Müller and Martin Schimmel. Of course, he had already moved to Bern. And when I saw these key results, our study, which we were doing in Geneva, satisfied all these things. And what was even more interesting was, I think one of these authors was the one who reviewed our paper when we tried to publish it in Clinical Oral Implants, because he or she specifically told us to mention these points in our discussion and say that this is one of those few studies which had the same implant system, different attachments. So long story short, this was a randomized control trial where we compared between ball attachments and bar attachments with long distal extensions. These are not short distal extensions. If you look carefully at these images, these distal extensions are almost 15 millimeters in length. And what we did was, oops, it says submitted for peer review. No, it's been published already. So we had 20 patients in each group, and both of them, both groups had interforaminal regular neck Straumann implants, which were either 4.1 or 3.3 millimeters. And what we checked was, we checked on the implant survival, success, and complications. And as functional measures, we checked on the chewing efficiency and maximum voluntary bite force. Structural measures, we checked on the peri-implant health, and of course, posterior mandibular bone height and bone height in the maxilla. And then, of course, when it comes to patient-related outcome measures, we checked on the denture satisfaction index and the OHIP, the oral health impact profile for edentulous patients. And our results, of course, we published only the 1-year results. Now the 3 and the 5-year results are getting ready to be published. My colleague Sabrina is going to do this from Geneva. Anyway, our 1-year results showed that as far as the implant survival was concerned, there were no implant losses in both groups, even with such a huge superstructure on the bar. And our implant lengths ranged from 6 millimeters all the way to 12. And despite this, there was no loss. And the range of the period the implants were in function was somewhere between 8.2 years, and the minimum was 1 year, and the maximum was 22. And when we checked the peri-implant condition, there was no, just like the previous Korean study which I showed you, even in our study, there was no difference at the peri-implant marginal bone loss or in the plaque and the bleeding index. But we did notice that in the experimental group, that's the bar group, the plaque and the bleeding index was slightly higher, and there was a tendency for it to be a little bit difficult to maintain, as you see in the picture. And you've already seen these patients. When it comes to chewing efficiency, both these patients with 2 different groups, there was no difference in the chewing efficiency, at least in the variance of hue. Subjectively, yes, we found some difference, but it's a subjective assessment. But between the groups, there was no difference. But what we did saw was the improvement in the chewing efficiency increased quite rapidly in the bar group, but in the overall function, it did not change. And the same with the oral health impact profile. In both groups, there was an improvement at 1 year, but it improved quicker at the bar group. And as far as the denture satisfaction was concerned, both the groups were happy. So what we concluded was that the results confirmed that the mandibular 2-implant overdentures with a CAD-CAM milled bar with long distal extensions are not an inferior treatment option to conventional IODs on retentive anchors in the short term. So we have to assess the prosthodontic maintenance aspect of this, and also the posterior bone loss in the mandible and the maxilla, which will be submitted as our 5-year report, which is about to come quite soon. Now, as far as patient satisfaction is concerned, I think it's important how you plan it, and it doesn't matter which kind of attachments you have. just like to show you that this was a patient who had her implants placed, as you can see in the first orthopantomogram. And this was there for almost 20 years. The teeth were lost, but none of the implants were lost. It was referred to me because they were not in a good position. And it was a special care patient who needed rehabilitation before her transplant surgeries. I decided not to add any more implants, but use the new over locator RTX because of the angular discrepancies. And this was her own testimonial. She speaks in French, of course, but then the subtitles. And her only wish was to bite into an apple with her teeth for almost 15 years. And she says that this is the first apple she's eaten in 15 years. So as far as the satisfaction with overdenture is concerned, it's amazing. So as take-home messages, what I would like to say is age is not a contraindication for implant therapy. We must be very clear with the goals of the implant therapy, and that is to restore function and improve nutrition as well as the oral health related quality of life. In order to do this, we must take into account the treatment predictors that can influence the success of implant therapy, and these include the cognitive status, manual dexterity, involvement of the family and caregivers in the initial planning, and of course, diet counseling. Thank you all for your kind attention, and I hope you found it interesting. I'm open for questions. That's my email at the bottom. So if you would like to contact me for anything, or even come to Zurich to see our clinic, you're most welcome. Thank you.
So thank you very much, Murali, for this splendid and comprehensive lecture. It's just amazing what you do there and how we share the same philosophy of taking care of those patients. And this is very interesting what you told us here today. And I have several comments to do here just to discuss, but we will have time to in another day to talk about all these further projects and all those results that you showed in your studies, and also that we have in our studies here. I remember when Martin came here, he said that he was less skeptical about the single implant overdenture. And I told you that you are invited to come here as soon as this pandemic situation will be over. It will be a great time for us here. And so, Murali, we have some questions here.
I see in the comments that I was being shot down for 2 implants and 4 implants.
No, not that much. But as you said, that in a country like us, in a middle-income country like Brazil, it's a very interesting approach. And as Professor Kerr in Germany says, it's always better one than none. And that's our perspective here is.
But you know, I want to tell you another thing. Okay, I also think one is better than none, but nothing is better than nonsense, isn't it? So now, if you look at it, look, I'm an old-fashioned prosthodontist. Let's discuss the biomechanics. Now,
we are all.
Yeah. So this let's say you put a single mandibular implant, okay, for this patient today. And let's say in a few years, he wants an upgrade. Now, if I'm driving a Prius today, I want to buy a Prius Plus later, but I must be able to do this. But you put one mandibular implant at the midline, you can't upgrade this. But if you put that same mandibular implant, single one, on one of the sides near the canines, or either one, and a few years down the line, he says, hey, you know, I can afford another implant, but at least you have the option to place it at the other canine. With this guy in the center, you can do nothing. It's a death sentence. It's finished. Over. That's it. Live with this one single midline implant for the rest of your life.
And we are going to address this concern in our multi-center study that is coming. Okay, and let's come to one question from Elena here. Would you please comment on 3 implant interforaminal overdenture? I think this should be the case.
What? Excuse me?
We had 3 implants over denture, in the interforaminal implants. We have some patients here that were not satisfied. I think two patients were not satisfied with the single and asked for 2. We did the overdenture retained by 3 implants. I think it's.
And does
it's a question.
And does this third implant actually improve the patient satisfaction? Does it?
Sure.
I think the implant which, firstly, I would assume that the distance between the 3 implants are quite large, because if they're not, then the implant in the middle offers no biomechanical advantage, because your retention would primarily be only by the 2 distal implants. The middle one would probably act as a stabilizing thing. It's the same concept as your removable partial dentures. You have the clasps on 2 extremities, and the one in the middle just acts as an indirect retainer. It never actually gives you retention. So if you place 3 implants, and if it's a bar, then I would assume it has an improvement. But if you place 3 implants and place only unsplinted attachments, then it cannot give any advantage.
Yes. Okay. But then again, yes, our patients with 3 implants with a bar over denture.
But Claudio, let's be honest. I think with 2 implants, and if you do a very, very good denture with conventional impression techniques and extensions of the border, I think 2 implants is magic. I mean, it's more of a psychological. I don't know. I have at least I have seen a lot of great success with 2 implants and mandibular denture with my patients, and also the others who had come. So I don't know exactly if the 3rd implant would be useful, but yes, if you use a 3rd implant and if you use a bar, it can have advantages.
Okay. What about the 4 implant overdenture with mini implants that we are? Did you have an experience with this?
Well, it works.
This treatment?
It really works, but I'm not a big fan of mini implants, because I told you they call them mini, but the length is like 10 millimeters plus. So there is a question of mini involved. And if this patient actually has 10 millimeters of bone height, I think you can place conventional implants with a very good surgeon with a little bit of bone augmentation, and it would do. I think cost-wise, it's doing great. I would use the mini. In the past, when I was starting my career as an implant prosthodontist, I was using mini implants as provisional implants. They call them, in those days, they call them TRIs, or transitional implants. So you would place them in between your final implants, and then you would load them till the final implants are ready to be loaded, and then you would cut off their heads and leave them dormant. But like I said, it was like this. And of course, in Switzerland, cost is a factor. But I mean, if a person, it's either they can either afford implants or not. There's not something in between. So for us, at least at the moment, either they can afford implants or they can't. And if they can afford implants, that means they have the money for the really nice ones. But mini implants are, I think, doing very well. I don't have great experience with it, but I think it's an option. Yes, it is a good option. But then that increases the numbers, and that increases also the you need an optimal height of the bone. Otherwise, you can't place these, right?
Sure. Thank you. We have other questions here. Elena also asks, in the study, in Shimel study, there is a wide variation in case follow-up in the clinical trial. In your opinion, what is the best way to work with this data against this difference? I think she's asking about differences in follow-up time in longitudinal study. I don't know exactly
which study was it? The mini implant study, or was it?
Yeah, I don't know. But probably because it's common in prospective study, we have patients with different follow-up periods, and we are able to manage this the statistics, I think. Marcella is asking, like in Brazil, we face a lot of resistance by patients when they talk about implant treatments. You talk about the importance of education of patients about the implant surgery procedures. How do you manage this conversation with the old patients?
Well, if they are cognitively normal, and if they understand, it takes some time to talk to them, many visits. I think if the old patients are candidates and they would benefit with having implant therapy, I think the conversation would start right from the diagnosis and while you're actually making the conventional prosthesis. And then by the time you finish the prosthesis, if they actually agree for the implants, it's okay. And you place the implants and then you just modify the prosthesis. That's how I would go with it. But if these patients are cognitively declined, then you have a big problem because the consent comes from the family members. And if the family members are not inclined to spend any money or have any advanced procedures done, that is a problem. And that's what we most of the time see happening because patients are not aware what they want because of their cognitive status, and some of the family members, they just don't care. Unfortunately, that's the situation, and they would not like to invest too much in the dental treatment, at least with advanced procedures. And this is sad for me to say it, but it is actual truth, and it happens. So yeah, it's not an easy conversation, and the insurance doesn't pay most of the times. So we have to also look at it in a different aspect, try and convince the social services who pay for the treatment sometimes. But like I said, it's a very difficult conversation. But some of the patients, if the dentures don't work, and then you try and talk to them and show them the benefits, use other patient models like modeling, like some of the patients, and it's a matter of motivation. And in the end, it all boils down to treatment burden. Is it going to cause a lot more problems to them in the health, surgery, pain, healing, and costs? And of course, cost is a factor in Switzerland too. I know you guys don't believe it, but
and this comes to our next question. It was observed in our study with the mini implants when treatment was offered for the patients without any costs. We identified we have almost 1/3 of patients refuse implants, but it's quite a difference between the intention to treat and the behavior. Most of the patients between when implants were offered and when the surgery was scheduled, many of these patients
disappeared
due to fear of surgery most of the time. Okay. Another question about immediate loading of mandibular overdenture.
Immediate loading of mandibular denture. What is the purpose? Well, I can. It depends, actually. You know, I can go on and on and on, talk about insertion torque and this torque and that torque and primary stability, blah, blah, blah. You have an elderly patient who is edentulous, and if you're not giving a fixed provisionalization or fixed solution, what is the point of loading an overdenture immediately? I mean, I don't see the point. Yeah, but it can be done. There are no studies which actually show this, but we did a consensus paper in 2014, and we did find out that early loading protocol was considered the best option for removable overdentures. And this early loading is about 6 weeks after implant placement. So if you're talking about all on 4 or all on 6, yeah, okay. This is another aspect. But for overdentures, I think a patient can afford to wait for 6 weeks, and you can be sure that the success rate is predictable, and it's much better.
Okay, well, I think we have some other questions, but I think it's time to finish our discussion. Murali has a very busy schedule. He has to travel to Italy today.
Yes, to Como, Lake Como.
Oh, okay. And we thank you for accepting our invitation. I'm sorry if it changed your plans to manage all those appointments that you have, but we are very happy to have you here. I would like to invite Gerry to come here. I sent also a, please, Murali, just a minute. Tulio, is the Tulio? I want to show you a picture that I will, Marcella.
Which picture? I don't see a picture.
1 minute. Marcella is trying to put in the screen, but that's was a very good opportunity to have you and Gerry together here. We had other meetings together, the three, but I would like to thank you. I think Marcella will not be able to show you the picture. It has a picture that we have together with our friends Martin and Frauke. I don't know if you saw this picture, but it can be another day. Oh, it's coming. Ha!
Oh,
here we are.
Oh, that was a nice day.
A nice day. And Martin was very emotive at this evening. But that's I'm very grateful to work with you guys, with Martin, and also with Frauke. I think it's a very, very special group, and we have a very special way of thinking about research and about clinical care for old patients and prosthodontics. And I'm very honored to share with you all of these projects and time that we have together. And you are invited to come here in the near future.
Brazil?
Oh, yeah.
It would be a pleasure. Let's plan.
Okay. It's on next target to come here. Okay, Murali, thank you very much. It seems you have to leave us now.
I will start listening to Gerry's lecture, and then I will escape in between. Gerry, please.
Okay.
No offense, yeah?
Okay, thank you very much, Murali. See you soon.
Thank you, and thank you all, and thank you for your team. It was a real pleasure. Thank you so much. Bye-bye.
Bye-bye. So, Gerry, now it's up to us. Okay. Once again, thank you very much for accepting our invitation. As I did with Murali, I have a brief introduction here. For those who don't know Gerry is from Northern Ireland. He is a researcher at the Center of Public Health at the Queen's University, Belfast. He's a specialist in restorative dentistry and prosthodontics. He is the former president of the Geriatric Oral Research Group of the RDR, for the International Association for Dental Research, past president of the RH division of the RDR, and the past president of the European College of Gerodontology. Currently, he is working with the National Institute for Health and Care Excellence, NICE, in the UK, and as a fellow for the next 5 years with a focus on improving oral health for older adults. He has several publications in top-ranked dental journals. We have some collaborations here with Gerry and other colleagues. He is the author of 2 recently released books, the Clinical Cases in Gerodontology and Clinical and Oral Health, Nutrition and Oral Health, sorry. As I told before, Gerry interacts with many researchers around the world, and I'm very proud to work with him. We have many collaborative work here at UFG. Gerry has been here in Goiânia before the pandemic, and we now have agreement between UFG and the Queen's University of Belfast. It was signed early this year, and we have between students and researchers. And this seminar is part of this project, Gerry, as we use some of the funding that we have from our Newton Fund project that you are also a co-applicant, and Gerry is also a co-applicant in another study that we have at large grant at ITI. So Gerry, thank you very much for accepting our invitation and to be here with us. And Gerry will talk about caries management for older adults. And we are very excited to hear you. Thank you very much. And the screen is yours, Gerry.
Thank you very much, Cláudio, and thank you very much for the invitation to come and speak with you this evening. I'm sorry I'm not with you in person in Brazil, but hopefully we can rectify that again in the near future. So this evening I'm going to talk about caries management in older adults. The reason that I'm going to speak about this is that in many countries like the United Kingdom, we are seeing fewer of the edentiate patients that Murali was describing in his presentation, and more of a partially dentate older population. So caries management and caries prevention becomes a very big issue within this particular patient group. So despite the flag which you seem to use to describe me on the flyer, I am coming to you from Ireland today. This is a map of Ireland, and I am with you from Belfast, which is in Northern Ireland. And previous to this, I worked in University College Cork, which is right down in the very south of the island of Ireland. This is where I'm speaking to you from today. This is a nice view of my office. This is the university in which I work in. This is Queen's University Belfast, one of the Russell Group universities in the United Kingdom, which means that we are very much focused on high quality research, and I'm very pleased to contribute to that in terms of oral health research, which I lead here in the university. And as Cláudio has described, I'm very proud of my connections with researchers around the world, and particularly those who I'm speaking to today from Brazil. So, as we have already discussed this evening, the world population is aging. Whenever you look at this in a little bit more detail, or you look at how this is described by some of our organizations, the United Nations describe this as demographic transition. And essentially what this means is that the largest part of the population which is growing are older adults. And this is because fertility rates are declining around the world. We have international migration, but of course that's been somewhat suspended with the COVID-19 pandemic. But the really big driver of this, of course, is dramatically increased life expectancy. And that's certainly something that we see here in the UK and Ireland. But some of that may have changed due to the COVID-19 pandemic. We're not quite sure just yet. Whenever we look at this and we look at the issue of dramatically increased life expectancy, this is a slide that I like to use to illustrate what is going on. So If you look at some of these facts and figures, 3 out of every 4 newborns will now live to the age of 60 years. 1 in 3 will live to the age of 80. And by 2045, global life expectancy will reach 76 years. That's not just highly economically developed countries, that's every country around the world. The average will reach 76 years. If you look at the infographic on the right-hand side of the screen, the figure which I always talk about is that in 2012, 810 million people were aged 60 years and over, and by 2050, that number will reach 2 billion. So these are really, really significant changes in the makeup of our populations in terms of population aging, and this has really significant impacts in terms of how we think about healthcare, how we develop healthcare, how we deliver healthcare to this aging population. So if we look in a little bit more detail, or we think about what's happening with the oral health of older adults, and as I said, I'm coming at this from a UK and Ireland perspective, we have seen significant improvements in the oral health of older adults. And these are trends which we see across many European countries. I'm aware these do not quite translate to all countries around the world, and there's a bit of a time lag with countries like Brazil, for example. But what we are seeing is increased levels of natural tooth retention and reduced rates of edentulousness in the UK. This is all being picked up by a longitudinal study which we have going on called the Adult Oral Health Study, which collects information on the oral health of people every 10 years. And this is going on in the UK at the minute. Some of the drivers for this are, of course, in terms of prevention, but also very much in terms of changing attitudes amongst older adults. Older adults would previously have been very accepting of treatment, which included removal of natural teeth and replacement with a removable prosthesis, but really that has changed very much over time. And as I said, we are now seeing the emergence of a partially dentate older population. So this picture very much represents what I see on a day-to-day basis in terms of what I see on my clinics. And if I was doing the job that I do, where I see, I take referrals for prosthodontic care in my hospital, and if I was doing this job 20 years ago or 30 years ago, the vast majority of the patients in my clinic would have been those on the left-hand side of the screen, edentate older adults who require complete replacement denture. But very much so, and I was treating patients this afternoon in my clinic, the picture on the right-hand side of the screen is much more indicative of what I now see on my clinic. So these are partially dentate older patients. As you can see, there are some natural teeth present, some that are missing. We're starting to see some of the sort of classic indicators of aging and chronic diseases amongst our older adults, where we have gingival recession, which exposes the root surface of some of these teeth. We have some demineralization. We have caries on some of these root surfaces. We have periodontal or gingival recession. All of these sorts of things are what we now see in our older population. So this is very indicative of what's going on within our population here. So certainly managing natural teeth is challenging in this population. We see increased incidences of chronic dental diseases. We see caries, we see periodontal disease, and we see tooth wear. And again, referring back to the Adult Oral Health Survey, as I referenced in the United Kingdom, this showed us that older dentate adults report an average of 1.5 decayed teeth and a high prevalence of root caries. The 2009 UK Adult Dental Health Survey reported that 27% of adults aged 65 to 74 years had evidence of dental caries, whilst that increased for our older age group. The 75 to 84-year-old age group had 40% that showed evidence of dental caries. So this is the nature of these chronic dental diseases. As patients age, the incidence and the prevalence of these diseases increase exponentially. This was an editorial which I was invited to write a number of years ago in Gerodontology, along with some of my colleagues, Professor Filipe Moreira from the National University of Singapore, Martin Schimmel and Frauke Müller, who you've already heard about, who are both from Switzerland. And basically, this was looking to try to put into context what the cost of managing our older adults and their oral health was as we went forward. So the estimates indicate that the treatment of oral disease accounts for 5% of public health spending across the European Union, with annual treatment costs rising from 54 billion euros in the year 2000 to 93 billion euros in 2020. Now, those are massive numbers, but sometimes they get lost a little bit. But it's the next sentence that really, I think, brings this home. So this is a cost greater than the management of stroke and dementia combined. That is what it costs to look after the oral health needs of our aging population in Europe. So these are really, really significant numbers. So why is this? Why is managing natural teeth amongst our older adults challenging? Because we're dealing with a challenging oral environment. We all know that there are challenges of looking after our older patients and their natural teeth. This is trying to quantify some of these challenges. So we know, unfortunately, that as people age, they tend to develop a diet which becomes rich in fermentable carbohydrates and sugars, and that fuels the cariogenic bacteria within the patient's mouths. There's evidence to suggest that as older patients age, their taste becomes diminished, so they tend to add things to their foods, their beverages to try and improve the taste, and quite often these are sugars, which then, of course, fuel those cariogenic bacteria. As I showed you in the picture a couple of slides ago, we have root surfaces which become exposed through gingival recession, and these, of course, are particularly prone to decay. Because we don't have enamel on the root surfaces, the exposed dentine is much more likely to decay much more quickly amongst our older adults. As you can see from the picture at the bottom of the screen, this is one of my patients who has arthritis in his hands. And as you can imagine, this really impacts on his toothbrushing and manual cleaning because he has lost his manual dexterity, or his manual dexterity is significantly impeded. And the other thing that we must remember, and I say this as a specialist prosthodontist, we have to be very careful about what it is we put into our patients' mouths, like removable partial dentures, because these can further complicate cleaning. And this is somewhat paradoxical. What we're putting in to replace missing teeth can actually expedite caries, periodontal breakdown in those remaining teeth, and actually lead to further tooth loss in this older population. The other thing, of course, that we have to think about is the issue of xerostomia and dry mouth. So complaints of xerostomia and dry mouth are very common amongst our older adults, and these can be due to a variety of reasons. This can be to radiotherapy. So, for example, I treat a lot of patients who have had head and neck oncology, and this is then managed through radiotherapy. They can have systemic diseases such as Sjogren's syndrome, diabetes, Alzheimer's disease. All of these things can impact on dry mouth. But these things are very minimal whenever we think about the issue of medications and multiple medications within this particular age group. So if you look at the fine print or the potential side effects of medications, up to 80% of prescription drugs can list or will list xerostomia and dry mouth as a potential side effect. And whenever we meet our older patients, certainly the patients that I see in my clinic, they are often taking 10, 11, 12, 13 different medications. So whenever you're getting into that issue of polypharmacy, the chances of these drugs causing xerostomia is rising exponentially with every one of those drugs. So this is a really, really significant issue amongst this older population, medication-induced xerostomia. I've talked about gingival recession, and of course, gingival recession is a product of periodontal disease. So is age a risk factor for periodontal disease? I mentioned periodontal disease as a chronic dental disease, and certainly in this population, the prevalence and severity of chronic periodontal disease will increase with age. Greater periodontal destruction in older adults generally reflects a lifetime of disease accumulation rather than an age-specific condition. So what we're seeing is this cumulative effect of periodontal breakdown amongst our older adults. Again, if we look at some data from the UK Adult Dental Health Survey, as we go through this and we look at our patients according to age, as we get into those patients who are 65 to 74 years old, you will see 77% of those patients will have pocketing and loss of attachment of more than 4 millimeters. As we go to 75 to 84-year-olds, 82% of those patients will have pocketing and loss of attachment of greater than 4 millimeters. So certainly, as you can see here, there is an age-related accumulation as we go through, reflected in pocketing and loss of attachment of our older adults. But certainly in terms of my patients, I'm not seeing pocketing or periodontal pocketing manifesting as periodontal disease in this particular age group. And as I already mentioned, of course, how we see this presenting is with gingival recession, so the product of periodontal destruction. Again, if you look along the top here, you'll see that as we go through the different age categories, again, if we look at 65 to 74-year-olds, 75 to 84-year-olds, 85-plus-year-olds, you're talking about patients who are 96, 98, 97% of these patients will present with gingival recession. And it will be present in multiple teeth, as you can see from the table. So this is how periodontal destruction presents in our older patients. And of course, if you put all of these factors together, if you put together gingival recession, you put together carbohydrate-rich diets, if you put together partial dentures in some of this patient group, the result is, of course, this disease process here. This is root caries. This is a disease that is unique to our older patients. We certainly don't see evidence of root caries in younger cohorts, but this is the product of the coming together of all of these etiological factors. So as I said, root caries is a disease almost unique to older adults associated with gingival recession, carbohydrate-rich diets, reduced manual cleaning, partial dentures, xerostomia associated with polypharmacy. And for those of us who are charged with providing care for these patients, who are charged with managing this disease, I can certainly say that managing root caries in older adults is a huge restorative challenge. It's very difficult to provide appropriate restorations. It's very difficult to retain restorations in place. And it's very, very difficult to control the etiology which is causing root caries to develop in the first place. Whenever we talk about managing any disease process, and Murali mentioned it in his presentation as well, of course, it's very important to think about prevention and how we think about how we instruct our patients to look after and care for their teeth going forward. So we need to think about patient education, and this is a picture here which I use in a lot of these lectures. This is a picture which Professor Frauke Müller from Switzerland lent me a number of years ago. And this illustrates a number of ways of thinking about how we might modify toothbrushes to help with our patients with perhaps reduced manual dexterity. So I showed you the example of the patient who has arthritis in his hands. So by putting something onto that toothbrush like a bicycle handle or a rubber noodle, this may well help that patient to hold their toothbrush better and do better manual cleaning of their remaining natural teeth. We need to think about the toothbrush and the toothpaste, the technique, and as I said, modifying the toothbrush. The other thing, of course, we can think about in these situations is the use of an electric toothbrush, which does tend to come with a larger, thicker handle. But of course, this may be financially prohibitive for some of our older patients. So we may think about some of these simple modifications instead. We need to think about how we instruct our patients in terms of fluoride products that we're using. Again, these are examples of some products which are available in the United Kingdom. The ones in the middle of the screen are normal over-the-counter toothpaste, but what I certainly prescribe for a lot of my older patients is the product on the bottom left-hand side of the screen, which is a high fluoride toothpaste called Durafat 5000. So this is something that has to be prescribed. It cannot be bought over the counter or in a pharmacy. I have to prescribe this for my older patients. We can also supplement this with Durafat varnish, which we can paint onto root surfaces. I would paint this onto perhaps denture abutments or overdenture abutments, for example, whenever I see my patients. And I think it can be very, very helpful to supplement these other fluoride products which are used at home. This is a high fluoride mouthwash, which is recommended both for older adults, but also for patients who are undergoing orthodontic treatment. And this can be, again, something very useful to help to supplement the other fluoride products which our older adults are using. This is an interesting product at the bottom of the screen here. This is silver diamine fluoride. This, of course, is something that can be used to hopefully arrest dental caries. It's not something that I have had the opportunity to use because this is not licensed for use in the United Kingdom, but I think there is certainly going to be a role for this in both gerodontology and also in pediatric dentistry in the near future. So certainly something to keep an eye on in this area. There are, of course, other additional products that we can think about using for our older adults, and I do recommend these for my older adults, as well as my patients who have undergone head and neck radiotherapy. So these are products that we have MI paste at the top of the screen and tooth mousse, which you may have heard of. These are not toothpaste, these are additional products which we can recommend for our patients. They contain the material or the active ingredient Recaldent, which is used to promote remineralization of the tooth surface. These are applied topically onto the teeth, not with a brush, but they're applied with the patient's finger and then rubbed along the exposed root surfaces, again, to try and prevent any further demineralization in those areas. So I've talked about prevention, I've talked about how we think about preventing dental caries amongst our older adults, but of course we do sometimes need to think about how we intervene operatively in these sorts of cases. So this all comes together in the concept known as minimally invasive dentistry, and I think this is something that is very, very applicable to our older adults. So this is a concept which has evolved with an increased understanding of dental disease. It's most often applied to the management of dental caries, and it's very much supported by the development and our increased understanding of adhesive restorative materials. As you can see here, the key principle of minimally invasive dentistry is early disease control or prevention, and the avoidance of surgical intervention until it is absolutely essential. So essentially trying to undertake caries management, but retain as much of the natural tooth surface as we possibly can. These are some of the, I suppose this is what predated minimally invasive dentistry, and there are still some elements of this in terms of our current teaching in terms of cariology, but this was very much traditional cavity designs as described by G.V. Black many years ago. These were really design classifications which were really for the use of dental amalgam. So these were designed to maximize the strength and the retention of non-adhesive material, i.e. dental amalgam. And these really predated adhesive dentistry. Unfortunately, as I said, some of these are still used, and I think we need to find a way to update our colleagues working with our older patients in terms of how we move away from some of these very traditional designs and move to some of the principles of minimally invasive dentistry, as I will talk about in the next couple of slides. This, of course, is something that we no longer practice, but was certainly something that was taught previously. This was the idea of extension for prevention. The idea that if there was caries in one part of a tooth, it was the job of the clinician to remove any other potential areas where caries could develop for that patient. So this was the idea that if there was caries in, for example, the interproximal area, then the pits and grooves on the occlusal surface would be removed to prevent against future decay. As I said, this is something that is now widely discredited and certainly not something we should be encouraging from our clinicians. So let's look in a little bit more detail about the principles of minimally invasive caries management. So the overarching principles are early caries diagnosis, assessment of individual risk for caries, the reduction of cariogenic bacteria to decrease the risk of further demineralization and cavitation, arresting of active lesions, remineralization and monitoring of non-cavitated arrested lesions, the placement of restorations in teeth with cavitated lesions using minimal cavity designs, not the designs that I just showed you in terms of G.V. Black's work or extension for prevention, and the repair rather than the replacement of defective restoration, something which I think is very, very important. So I wanted to pick out some of these things and talk a little bit more detail about them. So this is the idea of undertaking a caries risk assessment. Now, this is something which I feel many experienced clinicians are already doing. They may be doing it essentially in a non-formal way, but this is perhaps a way to record this in a more appropriate way for your patients. So a caries risk assessment is attempting to quantify how likely is my patient to develop caries in the future. I think it's important really that every patient should undergo caries risk assessment for dental disease. And this is something certainly that I teach my undergraduate students on the clinic. The idea of a caries risk assessment allows us to to detect at an early stage dental caries and control of active disease processes and minimize the need for surgical intervention. So if we can think about how likely this patient is to develop caries, we can tailor these things for that patient. The other idea is to try and empower that patient, give that patient control over what is going on to improve his or her oral health, and if successful, should require fewer appointments and fewer operative interventions for that patient. So there's a number of tools available for undertaking a caries risk assessment, and I'll show you an example of one in a second. As I said, it's a very useful educational tool, and essentially it's trying to bring together information on lots of etiological factors, including oral hygiene status, previous restorations, diet, presence of xerostomia. So patients are categorized as low or medium or high risk, and then you can use that to tailor your treatment and preventative regimes accordingly. The one thing I would say about a caries risk assessment is this is a dynamic concept. This will change over time. So for example, I described before about my older patients who come with a long list of medications. So if you have an older patient who is suddenly prescribed a new medication, that can influence xerostomia, and that can really change their caries risk assessment. So it's not something we do once for a patient and then forget about. It's something that we should be doing on a continuous basis for our patients. We can use some other diagnostic tests to supplement our caries risk assessment. So we can look at some of these products which are on the market to look at the presence or absence of cariogenic bacteria. And we can also look at doing things like salivary testing, looking at the volume, the pH, and the buffering capacity of saliva. Again, we're just trying to put all of this information together to get an overall status of how likely this patient is to develop caries in the future. This is the caries risk assessment tool which I use in my clinic. Now, this is a very simple undertaking. It has been made with essentially a traffic light system for green, orange, and red, red being for danger or high caries risk. And this is something, as I said, I have my undergraduate students using for all of their new patient assessments. So if you look down the left-hand side of the screen, there's a series of factors which are captured with this, including the patient's medical history, looking at the number of medications that they take, their social history, their dietary habits, although of course you can supplement this with a diet diary, their exposure to fluoride, what they're doing in terms of their home cleaning habits, and also the clinical evidence that we're collecting inside the patient's mouth. So whether they're cavitated or carious lesions, whether they've had recent fillings, whether they've had recent extractions of teeth, all of this goes into the caries risk assessment. So as you can see, if they are in a low caries risk, they will be hitting those scores in the green column. Moderate is orange, but the rule for this is if you have one of these factors which is in the red column, then the patient has an overall high caries risk. So as I said, this can then factor into the prevention we provide for these patients. This may mean that we decide to prescribe some high fluoride toothpaste, for example, but these are the things we can record for our patients and explain to them about how they reduce their caries risk. Another example of this is a very famous piece of software called the Cariogram, which was developed in Malmo in Sweden a number of years ago now. And essentially this combines all of the information that we spoke about before and summarizes this into a pie chart for the patient. This is a freely available piece of software which you can download from the link as you can see on the screen. And again, it's just another way to empower your patient, to give them some visual information about what it is that is causing them to be at risk of developing dental caries, and then what they can do to address some of those factors. So as part of the minimally invasive caries management approach, we do look at remineralization early lesions. So early lesions we try and avoid undertaking operative care for, and we look to try and remineralize any of these where we possibly can. So we know it is possible to arrest and reverse early carious lesions before they become cavitated. We know that there is a constant demineralization, remineralization cycle going on within the patient's mouth. And of course, whenever the pH drops below less than 5.5 in the patient's mouth, we can get demineralization of enamel and dentine. Fluoride, as we know, enhances the uptake of calcium and phosphate ions and forms fluorapatite, which demineralizes at a pH which is less, so making it more resistant to dental caries. So this is why prevention with fluoride, this is why looking at the fluoride intake or consumption of our patients is very important. And these are the things that we can think about to prevent dental caries. So these are the items we can undertake to encourage remineralization. We can look to decrease the frequency of intake of refined carbohydrates or sugars. So that's looking at the patient's diet, giving diet advice, looking at and analyzing their diets. We can ensure optimal plaque control, which is oral hygiene instruction, as we have talked about. We can look to ensure optimal salivary flow where we possibly can in older adults. This may mean, for example, discussing things with the patient's general medical practitioner, informing them of the issues around xerostomia of some of the medications which the patient may be prescribed. There may be options to have an alternative medication which does not induce xerostomia in this population. And of course, then conducting patient education, explaining all of these things to our patients and illustrating them and showing them the things that they can do to reduce the likelihood of developing dental caries. Unfortunately, there will come times when we do have to intervene operatively, but whenever the carious lesion reaches dentine, then we have to think about a minimally invasive surgical intervention. As I said at the outset, the cavity preparations are designed to conserve the maximum amount of enamel and dentine of the remaining natural tooth tissue, and we're only looking to remove the carious lesion. We are not looking to remove additional material to facilitate retention of a material like amalgam. We're going to think about restoring these with adhesive restoration, so only removing the carious lesion. So these are some examples of minimally invasive cavity designs that I would use with my patients today. So as you can see from the picture on the left, we have some class 2 restorations which we have to place on the premolar and molar for this patient. And instead of joining together all of these cavities for the patient, we keep them separate. We conserve the maximum amount of tooth tissue that we possibly can. Because we're going to use an adhesive material like composite in this case, we can do that. We don't need those additional retentive factors that we would need for an amalgam. Same as we can see on the premolar on the left and also on the right, we can do this with distal and mesial slots, for example, which have been cut into teeth. We can isolate these using adhesive technology. We can provide a good quality restoration for these patients. I wanted just to mention about managing existing restorations, because I think this is something that's often forgotten about whenever people talk about minimally invasive caries management. What we have to remember is that the replacement of existing restorations accounts for 50 to 71% of all restorations placed worldwide. Most of the restorations that are placed in practice or in dental practice are for secondary decay and replacing existing restorations. So whenever we're treating secondary caries, it is more conservative to repair rather than replace a restoration unless the defect is very large. Now, I am not saying for 1 minute that we ignore caries around an existing restoration, but I think there should be some thought given to, can we maintain some of the existing restoration and undertake a repair rather than removing the entire restoration. Even the most accurate operator, utilizing magnification with dental loops, for example, will find it impossible to remove a restoration without removing more and more of the natural tooth tissue. So the replacement of restorations results in loss of tooth structure and ultimately a reduction in the longevity of the tooth as cavity sizes increase when restorations are removed. Think about this for our older patients. Our older patients may already have had a number of replacement restorations. We want to try and break that cycle by perhaps thinking about repairing some of these restorations rather than simply replacing them time and time again. This is an example of where we can also think about repairing indirect restorations. This is a patient of mine who I was treating in a nursing home or a residential home. We did not have the facility to perhaps dismantle these fixed prostheses. We didn't have the option to cut off the patient's existing crowns. So instead of doing that, we had some caries around the margins of these, and we looked to remove this with a slow speed handpiece, and then we actually repaired this with glass ionomer in this case. So I'm not saying that this is a perfect treatment plan for this patient, but I think sometimes we have to think pragmatically about what we're doing and perhaps try and maintain existing restorations, even though they may not be perfect, because we don't have the opportunity to redo this for some of these patients. So certainly something worth thinking about. I wanted now to turn my attention to the atraumatic restorative treatment. And I think this goes very much hand in hand with the concept of minimally invasive dentistry. And I think it's actually the ultimate example of minimally invasive caries removal. So teeth are restored in this case with adhesive materials, most commonly glass ionomer, and hand instruments only are used to remove caries. Of course, we know that this was a technique that was first described to manage pediatric dentistry in remote settings, but this has now been adapted and utilized for older patients as well. Whenever we think about ART and we think about minimally invasive caries removal, we do have to rethink a little bit about our sort of thoughts on caries removal. Certainly whenever I was a dental student, I was taught to remove the entire carious lesion from a tooth, whereas what we now think about doing is trying to remove the caries infected dentine, which is the outermost superficial necrotic zone, where we have a high bacterial load and the dentinal tubular structure has been destroyed, and trying to maintain that inner caries affected dentine, where there's less mineral dissolution, lower bacterial content, and where the dentinal tubular structure can be essentially rebuilt in some of these cases. And as I said, the atraumatic restorative treatment really does take account of this. So these are some slides from my colleague, Dr. Cristiane Damata, who of course is from Brazil as well. These are the instruments which are used to undertake ART. So these are hand instruments used to remove caries from the teeth. So we don't use rotary instruments to undertake this procedure. As you can see here, this is a photograph where we're treating a patient in a nursing home. So this is one of the instruments used to open up the cavity and then to remove that outermost zone of caries infected dentine. What we do need to think about whenever we're using the ART technique is to use dentine conditioner, which is polyacrylic acid, and this does tend to improve the longevity of the restorations which are placed. Whenever we think about restoring these restoring these cavities, we are doing this with high viscosity glass ionomer. And then, of course, we're protecting the glass ionomer with a coating, so something like GC coat, or with Vaseline to inhibit that, or to allow the setting reaction to complete within the glass ionomer. So you can see some examples of restorations which have been placed using an ART technique at the top of the screen. And then on the picture here at the bottom, we can see one of these, a restoration which has been placed on an abutment tooth for a patient wearing a removable denture, and another one which is about to be undertaken for this patient. We need to check the occlusion and then reapply the coating for these restorations. As I said, the material that we use to restore cavities in this case is our glass ionomer cements. This is an adhesive restoration, so again, we can go about just removing the carious lesion. It is aesthetic. It does act as a fluoride reservoir, and it is relatively moisture tolerant. I say relatively. Ideally, you would have good moisture control whenever you are utilizing glass ionomer, but it's certainly something that is tolerant of some degree of moisture. Glass ionomers are chemically cured. You don't require a curing light for use of glass ionomers, and it can be used as a hand-mixed material, as you can see at the bottom of the screen, or it can come in capsules, as you have with Fuji Triage at the top of the screen. This is an example here. This is a patient who was treated in a nursing home, so away from the traditional dental setting. So this patient presented with caries on the palatal surface of an upper canine, as you can see here. We've used some hand instruments to remove the carious lesion. We've removed that outermost zone of caries infected dentine, but we're also happy to leave some of that softened material in the deepest part of the cavity. And then, as you can see here, this has been restored very successfully with a glass ionomer cement. This is Fuji 9 in this case. The Fuji 9 is then being placed, and then a protective coating placed over the top of this. The other huge advantage of the ART technique is that we don't need to use local anesthetic in this case. This can be done without local anesthetic. It can be done away from the traditional dental environment, as in a care home in this case. And as you can see, you can provide very successful restorations for these patients. I did mention about the issue of residential care homes, and this is something that we have a lot of here in the UK and Ireland and across Europe. The top statistic that I have quoted here says approximately 40% of these care home residents have some of their own remaining natural teeth. We're actually running a survey at the minute here in Northern Ireland, and probably the figure is closer to 55 to 60% of these patients have some of their own remaining natural teeth. So these are dependent older adults who can no longer live in their own home and then move into a residential care home setting. Provision of care can be very challenging, and there's very much variation in the delivery of care, and this is often very much focused on symptomatic relief, relieving problems for this particular age group, and education of care and medical staff is very much required. The reason, of course, that I mention this is that we can utilize the ART technique in these sorts of non-dental settings. These are some essentially news headlines that have appeared over the last number of years in terms of oral health in nursing homes. The story on the left-hand side of the screen comes from the New York Times, and then the story on the right-hand side comes from the Irish Times here in Ireland. And of course, the consistent finding is that the oral health of these patients is very challenging, and we don't really know how to go about providing care for this particular patient group. But I think things like ART and minimally invasive dentistry are really what we should be employing in these particular settings. So, of course, given that it is 2021, we can't think about implementing any of these new techniques unless we have some evidence to support their implementation. So I want to just briefly talk to you about a randomized controlled clinical trial that I worked on with Dr. Cristiani Damata whenever I was working in University College Cork. And this was a study that we looked at in terms of managing caries in patients from a geriatric day hospital and also in a community centre. So all of the patients received preventative care, including tooth cleaning and oral hygiene instruction. But essentially, we divided these patients into either receiving caries management using ART or a conventional technique with a rotary instrument using resin-modified glass ionomer. We were able to follow these patients up for 6, 12, and 24 months, and we've even been able to manage to follow some of these patients up for 5 years at this point. And we then look to assess these restorations according to some defined criteria for success. So as you can see, this was the clinical trial. We started off with randomizing over 100 patients. And by the end of this study, by the time we'd reached the 5-year follow-up, we had 43 patients who had treatment according to the conventional technique and 37 who received treatment according to the ART technique. And as I said, these were patients who were treated in their nursing home. They were treated outside of the normal clinical environment. So these are some of the ART restorations which Dr. D'Amata provided. As you can see here, these are some of these. So we've provided ART restorations on the labial surface and interproximal surfaces of some of these lower teeth in this case. And again, this has been done in a nursing home setting. This is a distribution of the surfaces that we treated as part of the study. Given the age of the population, which were all over the age of 65, as you can imagine, there were a lot of these were treating root surface lesions or root caries. But again, we did also treat those with interproximal lesions, buccal and lingual restorations, occlusal restorations, and a large number which were combined surfaces as well. So really, we did apply this to every available cavity that needed to be treated in these patients' mouths. So if we look at the results for this, and I'm sorry this is a very busy slide, but if we look at the red here, if we look at the 5-year follow-up for our ART restorations, we find that the cumulative survival was 68% for any of our ART restorations. And for our conventional treatment, so these are patients who were treated using a normal rotary instrument to remove caries, and then restoration with a glass ionomer, it was 66%. So certainly what we were able to demonstrate with this was that the ART technique is just as successful in restoring caries in older adults as our conventional treatment approaches. So like I said, if we look at this after 5 years, the cumulative survival probability of ART restorations was comparable, if not slightly superior, to conventional techniques. It was a very well accepted treatment in older adults, and it can be delivered very successfully in non-clinical environments, which of course was nursing homes in this case. These were some of the things that we looked at and we were able to determine were survival predictors for our ART restorations. So the size of the cavity played a role, the number of surfaces, the restorative material used, adequate removal of demineralized dentine, the operator training and experience. And what we mean by that is that the more of these restorations we placed, the better we got it, the better our success rate got, essentially. And the presence of adequate caries control measures. So this goes back to what I was talking about at the beginning in terms of prevention. We cannot simply use the ART technique without instituting preventative measures alongside that for our older adults. So the clinical applications of ART are that it's patient-friendly, it's minimally invasive, it must include a preventative regime, and it can be utilized in challenging non-clinical environments, including residential care homes. This can also be used by other members of the dental team, and I'm not quite sure how this applies to Brazil, but certainly here in the United Kingdom, we do have other members of our dental team, like dental nurses, dental hygienists, and dental therapists, who can also provide some of this treatment for our older adults. And we demonstrated that they were able to do this for this patient cohort. The other thing that we looked at was the cost effectiveness of this, and we were able to demonstrate that there were significant cost savings that could be produced by using the ART technique compared to conventional restorations. As I said, these were the economic costs, and essentially whenever we looked at the cost of equipment, the cost of sterilization for rotary instruments, all of these sorts of things, we were able to demonstrate that ART treatment was a more cost-effective solution to treat older adults after 1 year compared to conventional restorations, especially in out-of-surgery facilities and using alternative workforces such as hygienists. So certainly something to think about whenever treating caries in older adults. Just before I finish, I wanted to tie in something on tooth replacement and also then caries for our older adults. So as I said, I am a specialist prosthodontist, and I spend a lot of my time thinking about how we replace missing teeth for our partially dentate older adults. As you can see from the title of this slide, what we have to remember is that there is a biological cost associated with providing removable partial dentures. Removable partial dentures will accumulate plaque, they will increase caries incidence, and they will increase the likelihood of periodontal destruction amongst remaining natural teeth, and they will increase the likelihood of further tooth loss. Whenever we think about providing removable partial dentures, we must ensure that good oral hygiene is absolutely crucial. So as part of this, this slide, of course, I have showed you some lovely examples of cobalt chrome framework dentures that I make for my patients. But of course, this is not the reality of how most of my patients present with removable partial dentures. This is the reality really of what I see from patients who are treated in general dental practice, where the vast majority of dentures are acrylic dentures. They cover a huge amount of the gingival margins, the remaining structures in the mouth, and they accumulate huge amounts of plaque around the abutment teeth. This was a picture I showed you already. This is the patient who has had, this patient having removed their lower partial denture. So this patient has already had caries treated in one of their abutment teeth and then has active caries in the other abutment tooth. And this is very much what I see amongst my older patients. So this is the reality of RPDs. So I wanted to talk to you about some alternatives and how we think about replacing missing teeth for this cohort without thinking about removable partial dentures. And certainly something that I use a lot with my patients is the shortened dental arch concept. So this is not a new concept. It's been around for a long time. It was first discussed by Professor Arndt Kaiser at the University of Nijmegen in the Netherlands in the early 1980s. And what he basically said was it is not necessary to replace all missing natural teeth. And he suggested that a shortened dental arch of 10 including pairs of teeth would be able to provide patients with something that is aesthetic, which is well accepted and does not require a huge amount of maintenance. So not providing treatment for large molar teeth or not replacing large molar teeth will help to provide this sort of treatment for our older patients. This is an example of a natural shortened dental arch. So this is an older patient who has missing posterior units, as you can see on the lower left and also the lower right. And I am certainly not thinking about replacing these units for this patient because they are functioning well, they can eat, they can chew, they have good aesthetics, and they can maintain this collection of remaining natural teeth. Of course, we don't all see patients who present with a nice arrangement of 10 including pairs of teeth. What we often see are patients who need to be restored to a shortened dental arch. So these are patients who have some remaining natural teeth, and if we provide them with some treatment, they can get to that requisite 10 including pairs of teeth, but we don't do this with a removable partial denture. So we can do this with conventional fixed prosthodontics, as you can see here. We can do it with resin bonded bridge work, as I'll talk about in a second. We can do it with dental implants, or we can do it with things like fiber reinforced composite bridge work. This is an example here. This is one of my patients who had a periodontally involved lower incisor tooth. This tooth needed to be extracted, and instead of providing this patient with a removable partial denture, we looked to provide a fiber reinforced composite bridge where we used the patient's existing tooth, we extracted the tooth, we removed the root, and then we simply bonded it into place by utilizing the teeth on both sides of the space. Now, this is not going to last for 10 to 15 years, but this lasted for the next 3 years and was then replaced with an adhesive bridge for this patient. This is an example of resin bonded bridge work, which I have provided to restore my patient to a shortened dental arch. This is a patient who is missing their 2 upper anterior teeth here, as you can see, and 2 lower anterior teeth, as you can see in this picture. They also have missing units towards the back of the mouth on the left and on the right, but by providing resin bonded bridge work here and here, excuse me, we're able to restore this patient to 10 including pairs of teeth and provide them with something that's aesthetic, something they can maintain, and something they can function with very well. Another example here where a patient has been restored to a shortened dental arch using some adhesive bridge work here, here, and here in this case to replace 3 missing units of teeth rather than a removable partial denture, for example, which would cover over the lingual surface of these remaining natural teeth and potentially to periodontal breakdown, caries, and further tooth loss. So again, just as I showed you an example of a randomized controlled trial for our ART technique, this is an example. This is a randomized controlled trial which we have run looking at tooth replacement for partially dentate older patients. So again, these were patients who were recruited from a geriatric day hospital. They were recruited from nursing homes, patients who required treatment to replace their missing natural teeth. Half of these patients were restored to a shortened dental arch, as you can see here, using adhesive bridge work, and the other half were restored with removable partial dentures with cobalt chrome framework designs. Again, we have followed these patients up for over 2 to 3 years now and published a lot of outputs from this study. But the one thing that I wanted to leave you with, this was the last slide to show you essentially the caries incidence and how many of these patients develop caries in our shortened dental arch group compared to our removable partial denture group. So the number of new carious lesions in our shortened dental arch group was less than half for each of our SDA patients versus around 1.5 new carious lesions for our removable partial denture group. Where we had recurrent carious lesions, again, very similar for our SDA group, but again, more than 3 times as many for our removable partial denture group. So essentially, those patients who were restored to a shortened dental arch versus those who were restored to removable partial dentures were significantly less likely to develop caries 2 years after follow-up in this randomized controlled clinical trial. So again, thinking about not just prevention, not just how we think about managing caries in this group, but thinking about the things we put into the patient's mouth which may have an impact on how they develop caries going forward. So I'm going to sum up at this point. So we have an increasingly partially dentate older population, and managing chronic dental diseases in this group is certainly very challenging. I hope I've shown you that there should be a move towards minimally invasive dentistry and minimally invasive caries management. Adhesive materials are very much the key to this technique, including glass ionomer as part of ART. Excuse me. But caries risk management and application of preventative regimes are absolutely vital for this group. So thank you very much for your attention and your invitation today, and I'd be very happy to try and answer any questions that you may have.
So, Gerry, thank you very much for your presentation. Nice mug from UFG. Thank you. And we have some questions here. I will try to summarize the whole idea of the questions. Some of them are related, and I have also questions about implementation of all these pragmatic strategies for the healthcare of old patients. That's the current stage that we are here at our university, and considering the curriculum of dentistry in the whole South America, that is gerodontology is not a specific topic that is more stressed in the dental education. So how you think we can influence or convince students and colleagues about these programmatic approaches? In some cases, they view some strategies like repair of restorations, shortened dental arc, or adhesive bridges, like those are not high standard dental procedures, but it's very applied for this type of patients. And many times we have patients that we have treatment plans that are the normative way, and we see people, old people in our comprehensive clinical care here for 2 or 3 or 4 years in treatment with low resolution of the major problem of these patients. How you see, how could be these strategies, considering that we are implementing the course of gerodontology in our curriculum?
So I think I think first and foremost, what I would say is that some of the strategies that I am talking about are not universally accepted in this country either. There's still very much a focus on traditional methods of caries removal. There's still very much a focus in some areas on replacing all missing natural teeth, and arguments that, well, the shortened dental arch is not, ideal treatment for older patients and things like that. But all that we can try and do is to try and continue to show through high quality studies, through high quality research, that actually we can show very positive results with this. With ART, for example, we have shown, through the randomized controlled trial that we have talked about, we have demonstrated that the success rates of restorations placed using an ART approach are just as good, if not better, than conventional approaches. And also, what is often forgotten about in some of this is the patient's perspective on some of these treatments. So, for example, I've talked about, we have undertaken qualitative work to look at the patient's viewpoint on some of these treatments. We've demonstrated significant improvements in quality of life for patients treated using shortened dental arch approach versus removable partial dentures, for example. And I don't think that the people who are arguing against implementing these approaches are often considering the patient's viewpoint in what they are talking about. I think we have captured that in a lot of our research. And I think now the challenge is that we implement that and we get the message out that this is just as an appropriate way to do things, and that this can provide success, which is just as positive, if not better, than what has been done before. There will always be resistance to new ideas. There will always be resistance to change. But all we have to do is to keep demonstrating this, keep undertaking the sort of research that we already do, and show people these results. Patients prefer it. We've demonstrated it's more cost effective. And these are the sorts of important factors that we need to think about.
Okay, thank you. We have a very specific question here, is how about the use of water peak, water faucets? You have experience with such?
Yeah, I mean, so I'm assuming as a means of intradental cleaning. So I think that can be very useful. I think with all of these things, as I showed with the, how we can adapt toothbrushes, for example, I think we need to think about how we're instructing our patients and how easy it is for them to carry out some of these techniques. So, for example, there's very little point in instructing a patient in their 80s who has arthritis, for example, on the use of how to floss between their lower molar teeth, for example. If a water pick is, as it is in this country, something that is a little bit more easy for patients to use, something that's easier for them to hold on to, then I think that can be very positive for this age group. It's if it is useful for these particular patients, I'm very supportive. It's not something that I use a lot, but certainly I have lots of patients who think that they are very useful, and I'm very happy to encourage that.
Okay, thank you. I'm trying to manage it. There are many questions here, Gerry. Just in the topic of automatic restorative treatment, you showed very good results in your study. But our student here, he's from Jamaica, he's asking about, he's commenting that some patients have fear from treatments without anesthesia, and what to manage these patients and fear of these patients about receiving that treatment. Is it a real problem in your practice?
So, I mean, I think with all of these sorts of treatments, I think it involves a discussion with each of the patients. I mean, we very much are in the era of informed consent. So patients need to be informed about what it is we are proposing. The evidence again is there to show that without local anesthetic, this can be very, very useful. This has been applied widely to children who you would imagine would be, again, very fearful of some of these sorts of techniques if this was an issue. But again, it's the proof is in demonstrating this to the patient. It's not a particular issue that I have to say, because I generally find that many of my older patients do not particularly like receiving local anesthesia. So if there's an option to have something done without it, they are generally quite happy to do that. But again, it's about having an honest conversation with the patient, describing what it is that you're going to do. Of course, you can provide local anesthesia with it if the patient is very, very concerned. The most important part of ART is the removal of that outer layer of caries infected dentine and allowing to remain in place the inner layer of caries affected dentine. So if this can be done without local anesthetic, then again, I think that's a very positive move. But I think it's about informing the patient about what you're going to do and ensuring that they're happy to proceed on that basis.
Okay, thank you. We have a question here from Rejane. You know her. We
Yes.
have a dinner here in Goiânia. Tomorrow we have a seminar with your friend Paul, and she's asking about, considering that the high incidence of oral cancer in older patients, do you have any strategy for monitoring these individuals at high risk for the disease? And you also collect other information related to risk factors or habits, and associate them with decision to make a biopsy or not, for example.
So I'm probably not the best person to discuss that particular topic, because I am not involved in that sort of treatment with older adults. I do provide treatment for patients who have had head and neck cancer, but generally to rehabilitate them after they have had treatment. So I don't see them at a screening appointment. But what I would say is that this is becoming a very significant issue here at the minute with COVID-19. So what we have had happen here in Northern Ireland is that many dental services in general dental practice or in primary care have been very restricted as a result of COVID-19. So patients have been unable to attend their general dental practitioner for screenings for oral cancer. And what we are now seeing in the stage that I see these patients, the data that I saw yesterday suggested that about 60% of our patients who are now attending clinics in the hospital are a stage 4 head and neck oncology lesion at presentation. So these are the really devastating effects that COVID-19 is having here. So again, as Rejane suggests, these are generally older patients. These are patients who have not been attending their general dental practitioner. And unfortunately, what we are now seeing is these patients are presenting at a very late stage with very advanced cancer. So certainly providing screening is very important for these patients, but I think that's something that's best done in general practice by patients attending on a regular basis. And certainly what our dentists here in Northern Ireland are instructed to do when they're undergraduate students is to undertake a cancer screening for all of these patients by conducting a full intraoral and extraoral examination. And then this allows them to pick up anything at an early stage. But unfortunately, we are now seeing at the minute the impact of disrupting and dismantling that system on cancer here in Northern Ireland.
Okay, thank you. We have a last question here. It's about the integration of your dental service, about your experience in Queen's University of Belfast. What are the difficulties that you face to integrate the work with the clinical dentistry, with the hospital, and I will include here nursing homes, how it occurs in your current practice now? And this is a very difficult that we are facing here in our university.
It is difficult. So here in Northern Ireland, we have so I work as a hospital consultant, and I am essentially the leader of a team of dentists who provide care for patients. Through my interest in care for older adults, I have also, I suppose, not formally taken on a role to lead some of our colleagues who work exclusively in nursing homes. So, for example, Murali and his department in Zurich, they are responsible for nursing homes in the Zurich area. That isn't really the case here, but I have taken on some of that responsibility and provide instruction and provide training for the dentists locally who provide treatment in nursing homes. It's very difficult, and it's very difficult because the number of patients who are now in nursing homes and also the oral health needs of patients who are in nursing homes is increasing all the time, and we simply don't have enough people to care for all of these sorts of patients. What my ambition is to essentially allow our dental students to undertake visits to nursing homes and provide some of that care, but I haven't quite managed to develop that just yet. This was planned in late 2019, but as we all know, the world stopped in March 2020, so we haven't been able to implement some of these things. But I think this would be a very good it would be a very good training opportunity for dental undergraduates, and also it would be very much used to serve or to provide care for an underserved population. So it is a challenge, but it's something we're trying to work through. And as I say, I would like to see undergraduate dental students taking more of an active role in care for patients in nursing homes.
Okay, thank you, Gerry. We are coming to the end, and I'd like again to thank you very much for collaborating again with us, not only with our project, but you accepted our invitation very quickly. I was very happy to have you here and to work with you. And I would like, before ending, I would like to invite Marcella and Paula to the screen. They were working here in the backstage. Okay, Marcella is in Bern. That's part of her sandwich period in her PhD studies. And Ana Paula is our postdoc here in our program. Thank you very much for helping us here, managing the questions and all the technical part of this. Okay, thank you very much. Thank you very much, Gerry.
Thank you.
Hope to see you soon. If we didn't have a pandemic, this year would be your third visit to Brazil. Yeah, that was the plan before COVID-19. But we have I think there is much more to come, and you are a very, very important partner to us here. Thank you very much, and be safe. I've heard that the COVID situation is not very good in the UK. It's becoming a little bit worse. I don't know if it's the reality. I hope you all be safe, and we go through all these difficulties, and hope to see you soon here in Brazil again. Okay?
Sure.
Thank you very much. And yeah, I look forward to visiting you again in the hopefully near future.
Thank you very much.
Thank you so much, Gerry.
Okay, so this is the end of our research group seminar number 4, and hope to see you again tomorrow in the second day of our international meeting. Okay, thank you very much. Bye-bye. Take care. Thank you, Gerry.
Thank you.
Bye-bye.